Thank you, Stephen, for your massive introduction to this topic. I hope that has provided our viewers with a good framework to understand everything that we're going to speak about tonight. And for those of you at home who have a headache, keep those questions in the chat, take a sip of your wine, and we're going to move swiftly on into the next section. So tonight we have Associate Professor Carolyn Cooper and Dr. Jennifer Borowsky, who are going to lead us into how to read a lung cancer molecular report. Carolyn is an anatomical pathologist at Pathology Queensland at Princess Alexandra Hospital. She has done research in biomarkers in cancer and prediction of response to immune checkpoint blockade. And Jennifer is also an anatomical pathologist from Princess Alexandra, where she oversees molecular sequencing of solid tumours. Thanks, Carolyn and Jen.
Thank you, Ben, for that very kind introduction, and thanks also to Stephen, who's done an awesome job of setting the scene for molecular testing. Just to say that I am an anatomical pathologist and I don't report molecular pathology, which is why Jen and I come as a double act. But what I do is do a lot of lung cancer reporting and handling of the specimens and liaising with the clinical team. So we thought between us that we could do a little bit of a Q&A session and really pick apart a molecular pathology report so that you as clinicians know what all this means. Often these reports seem a little bit overwhelming. They're often multiple pages, very text dense and intimidating, but we're aiming to try and break down the structure of the report to give you some practical tips. Some of the questions will be pretty broad or general, but please put the questions in the chat if there's anything you need expanding on, because we have two national experts and international experts, I would say, on molecular pathology, and Stephen and Jen here. So just very briefly, why are we doing this? I don't know that I need to tell an audience of clinicians why, but really we're looking to find specific alterations, meaning that the patient can access an approved and reimbursed targeted agent with proven benefit, or identify patients for molecularly selected clinical trials, and to aim not only with diagnosis but also prognosis and therapeutics. As has been mentioned, optimally patients should be discussed at a molecular tumour board. This is not always available, but ideally would be so. And this would include discussion of potential genomic alterations that can be related to hereditary tumour syndromes. So moving on to the next slide, what's really important and what we have a lot of dialogue about is really what kind of samples can be tested. This is important not only at diagnosis, but also at progression and in diagnosis of metastatic disease. So we can test a lot of samples in the pathology laboratory. Cytology specimens are often excellent, in particular, a lot of the FNA and EBUS specimens that we get. Fluids can be suitable as well, such as pleural or pericardial. Most of the specimens we deal with are histopathology specimens. So these, in the setting of lung cancer, would be small core biopsies or bronchial biopsies or resection specimens. A general comment is that for many laboratories, decalcified specimens are not suitable for molecular testing. This is not true across the board. Some laboratories have sort of more gentle methods of decalcifying bony specimens. If you did want to, for example, a bone metastasis was the only suitable sample to be biopsied, I would encourage you to liaise very closely with your pathology laboratory to see if that is something that you would get a result from before embarking upon it. This is just a clinical picture here of what might be a very large primary tumour or metastasis, but in fact we often get very tiny, 1 to 2 millimetres bits of tissue, and within those 1 to 2 millimetre samples we may only get, less than a millimetre of tumour to deal with. So obviously the tissue is very precious. The procedures are not without risk, and we do our very, very best to do the best we can with these. So what do we do? As Stephen's mentioned, we have to firstly confirm the diagnosis. This may require the use of immunohistochemistry. And on the right-hand panel, you can see metastatic lung adenocarcinoma, which is TTF1 positive. We still widely use ALK D5F3 to identify those that may have ALK rearrangements. And that's, in this example, the bottom panel shows this confirmed on FISH. On the left bottom panel, there's a cytology specimen with, on the bottom left, some normal bronchial cells, and on the top right, lung adenocarcinoma. And these can often be very suitable specimens, particularly in some laboratory. Liquid-based cytology is used as a preservative for transport and gives excellent DNA yield, but we can also use cell blocks. We also can assess adequacy and estimate tumour cell content. I'll hand over to Jen now to talk a little bit more about the essentials in a molecular report.
So just before we move on to an actual report, just in terms of what the reporting guidelines are in Australia, we have 3 main NPAC documents that give some guidance as to what should go into a molecular pathology report. In terms of the Pathology College, the FRCPA, it's not very prescriptive. It's more principle-driven in what should go in one of those reports, which is quite different to what the Americans, for example, have. They have very prescriptive guidelines, which are almost at a field level. This is A, B, and C, exactly what you need to put in. So combined in these documents, there will be some variability across Australian labs, but most people should have these main things within the report, including patient and request identifiers, the specimen ID and the context in which it's been taken, the test that was performed. As Stephen mentioned, there's quite big differences between tests. It's important to know which one was performed, what the results are, what the interpretation is in an unambiguous way, what the limitations of the test are, which can be very important, especially if you're asking for something specific and it may be in smaller print towards the bottom of the report, and we'll go through that. Sending quality and validity statements, so anything that may have impacted the quality of the report, and of course date and report traceability, what lab put it out and who authorised the report.
So we'll move on to case number 1. This is, a very common case that we see all the time. Older male with a GGO, query cancer, had a biopsy, acinin-predominant adenocarcinoma, was TTF1 positive. There was an estimate, perhaps not well shown in this picture, of 40% tumour content.
And we performed a 27-gene DNA next-generation sequencing panel on that. There's a list of the genes there. It was amplicon-based, which Stephen touched on before, as opposed to capture hybrid. As I said, it was 27 genes, and importantly, it doesn't measure copy number variations, fusions, TMB, MSI, HRD, or any mutational signatures. So mostly SNVs and small indels. This is the kind of thing that the laboratory scientists and molecular pathologists may be dealing with. This will be widely variable across laboratories. This is just an example of an Excel spreadsheet with the different gene outputs, the coverage limitations in there as well, and specific details that need to go into the report. And this is what it's used by this specific laboratory to make this report, which is on the next slide.
So thankfully, as clinicians, you don't have to deal with those Excel spreadsheets, which are pretty overwhelming. This is an example of a report. These obviously vary from laboratory to laboratory, but all the labs will issue reports which will have this information somewhere. It may be in a different order, it might have different headings, but it will be there. So we thought we'd actually go through in quite some detail a pretty straightforward case with an EGFR mutation and sort of discuss what you need to be looking out for. So in the first red box is the key finding of the report. And Stephen also showed this before with his case. There's a whole string of letters and numbers. What does it actually mean, Jen?
So in the first red box, I believe you can't see my mouse, so it's just the first one from the left top. First, you've got your gene name, which in this case is EGFR, and then you have an NM. So this is a type of transcript, and I think the simplest way to think about this is that there's quite a few different editions of how you can look at the same gene. And there's been a kind of consensus between the different groups that brought out all of these different editions or transcripts, and there's now a more homogeneity across laboratories. They use this main transcript for oncology reports. It should be pretty consistent, but it's very important to put in there because your C dot and your P dot, which come next, could change depending on which edition you're using of looking at that gene. So that's what that NM is for. The C dot is where, at which nucleotide your variant is located. And here you can see it's located at nucleotide 2235. So it starts at the start of the gene, nucleotide 1, and goes all the way to the end, whatever nucleotide it is. That will depend on the gene. But in this one, at 2235, there's a deletion, which is what the del is for. And that includes 2235 all the way through to 2249. And then next comes the P dot, and this is telling you what amino acid change there is. So each 3 nucleotides code for an amino acid. So here you've got a deletion of those nucleotides, causing a deletion from glutamate 746 amino acid location all the way through to alanine 750. And this is an in-frame exon 19 deletion, which will be described in the box below it, but up here it also says variant detected, and then it has the variant allele frequency, which in simple terms is the number of cells or DNA copies that this particular variant is identified in. So if you remember, the tumor content was 40%, so this would be half of that, so a heterogeneous suddenly forgotten the word for that, but yes, continue, Caroline.
All right, and thanks, Jen. There's a blue arrow for the line sort of 2 below that red box where it says KRAS MET C assay limitations. I'm pretty interested to know, and I think oncologists need to know, what does this mean?
Yeah, so it will depend slightly on which lab has put the report out, but if there are genes that are important in that particular tumor type, and this particular lab has put the genes that they've deemed important out of the 27 at the top here, they've put the variant that was identified, and then they've put the genes where there was no clinically significant variant found, and also the ones where there's some assay limitation. So at the top here, they're saying that there's some assay limitations, whatever they are, and in this particular case, coverage in KRAS and in MET. Which, if you go down here under assay limitations, it spells out genes with limited coverage with a limit of detection of 6 to 10% in KRAS, and it lists the exon, and MET, and it lists the exon as well. And I think a kind of a simple way to think about that is that the lower the coverage is, the harder it is going to be to find a variant. So you're going to need to have that variant present in a higher number of cells within your sample to be able to find it. And it will be somewhere between 6 to 10%, whereas the usual limit of detection is 5%.
So really important for everyone to realise that the assay limitations are important because you may get a false negative result, particularly if there is one gene of interest for your treatment. Now, I think we're taking a little bit longer than we did in rehearsal, so we'll move it along a little more. The interpretation there, I guess now this is where it's really important to have a very good working relationship with your molecular pathologist. So the molecular pathologist then take the result and put it into a clinical context in this next, which is shown in this next box.
Yeah, and here you need to have your tier, which as Stephen described earlier. You need to spell out what kind of variant you're dealing with, and it needs to be, the impact guidelines are quite specific on this. It needs to be in a way that is understandable to a clinician, and it needs to have, if there are any prognostic, diagnostic or therapeutic indication, it needs to be spelled out as well. If there's any important negatives, for example, if this was a non-small cell lung cancer that did not have an EGFR variant, it would also need to spell out that there was no EGFR variant and the patient probably wouldn't respond to EGFR TKI. And also in here, depending on the lab, they may put any additional testing that should or should not be undertaken in this particular context.
Excellent. Now, moving down to the bottom, there's really a lot of detail on the methods. Now, we won't go back through all of the methods because Stephen very comprehensively covered that. But what I thought was really important, and this is a clinical question that we get not infrequently, which is what tier should we be actioning? If something is issued a report in a tier 3, is that something that is important? And I think Stephen described this really well, that tier 1 and 2 is where the money is for the clinical action at the moment. Tier 3 is where we really just don't have enough information to date to determine whether or not this is going to be clinically actionable or not. And tier 4 in general aren't reported because they're benign. Is that correct, Jen?
Yes, so most laboratories across Australia do report tier 3s, but not all of them do. So there are some that don't report tier 4s and tier 3s. This particular laboratory does report them when they are present, just for completeness in case they are required at a later point. But yes, tier 3s should not be used for any sort of diagnostic, prognostic or therapeutic decision making. And tier 4s are not included.
I think we'll move on to the next case. So this is a little bit of a different from your everyday lung cancer. This is a 71-year-old patient with an enlarged right axillary node. And interestingly, this patient had a history of some skin cancers, but nothing was really known about that, but nothing else in their history. The morphology as seen in the top right is quite different than the last case. It shows a tumour which morphologically looks like a high-grade neuroendocrine carcinoma, such as a small cell carcinoma. And in this particular case, the histological differential diagnosis came down to, was this metastatic small cell lung cancer or was it metastatic Merkel cell carcinoma, given their history of previous skin cancers?
And this patient actually underwent whole exome sequencing. So they had DNA-based WES testing with matched germline blood sample. And what they found for this patient is they found a high tumour mutational burden. There's quite a few variants, which I won't be showing tonight. And they also found a cosmic mutational signature 7, which the report detailed as likely due to ultraviolet light exposure. And we'll talk through that a little bit. Yeah.
This is really important, I think, because often people talk, and Stephen mentioned this too, about these signatures, but it can be pretty confusing if you're not familiar with them. So I think, Jen, you're going to explain a little bit more about them briefly.
Yes, I think I'll keep it brief and simple. I think one way to think about the mutational signatures is that they are a way of damage recognition. So different insults, whether that's UV radiation, tobacco smoking, even aging, different chemotherapy agents can cause different types of damage within our genome. And those can be picked up in various ways. There are quite a few different mutational signature kind of cohorts. There's research-based one, and the ones that are most commonly clinically used are these ones from Cosmic. We've put the website link in for you to have a look at. And even within the Cosmic signatures, they look at different types. There's single-base substitution signatures. There's also small indel signatures. There's fusion signatures, all sorts. Again, within the Cosmic, the most common clinically used, the SBS signatures are probably by far the most commonly used ones. There's over 100 different SBS numbers pertaining to different mutational signatures. A little snapshot here, you can see there's an HRD signature, there's a tobacco smoking signature, and here's the ones that were picked up on our tests, which were SBS 7A and SBS 7B, which were the UV light exposure signatures.
Thanks, Jen. And I think just to finish off our section, we're going to just briefly touch on tumour mutation burden. This is bandied around a lot in medical oncology fields in a number of different tumour types. So what can you tell us about that?
So our tumour that we had before had a high tumour mutational burden. So obviously for our differential, we had a high tumour mutational burden that was associated with a UV signature. So in this particular case, it was indicative of a metastatic Merkel cell carcinoma rather than a lung primary, due to UV signature generally indicating a cutaneous origin. In terms of the tumour mutational burden, that can be high in many cancer types, and simply put, it's a quantitative measure of the load of abnormal proteins which are being generated by the mutations that you have. So the more mutations that you have, the more abnormal proteins or neoantigens are being produced, which in a way kind of primes the immune system. And when immunotherapy is provided, it is more likely to be responsive to that. And there's different categories of TMB. TMB above 10 is associated with a few FDA approvals and is used generally to indicate high tumour mutational burden. But I will say there's a bit of work going into trying to make that more specific to tumour type, as not every tumour type should probably have a cutoff of 10. And this was a ultra-mutated tumour, which is generally a word associated with tumour mutational burden over 100. So this is 120-something.
And thanks, Jen. And I think that wraps up our section. Thank you very much. And I would encourage you to put questions in the chat.